You can start sharing, sir, and we can begin.
Okay, can you see my slides?
Yes, sir. You can start na po, sir.
And Prof.
Okay.
Yes, Prof.
Okay. Good afternoon. Okay. So again, I am Dr. Reynaldo Hoson. Okay. I was asked to give a lecture with this title, Organization and Management of a Department of Surgery for HA202, with the following prescribed learning outcomes or objectives. Understand the philosophy, objectives, structure, staffing, policies, systems, and methods in running a department of surgery of a hospital. Number two, understand the roles and relationship of the different components of the department of surgery. So this is within the department. Then describe the responsibilities of hospital managers, the CEOs, the hospital directors in directing and coordinating the Department of Surgery. And number four, understand the challenges that might be encountered in the Department of Surgery and to recommend solutions thereto. I will use this generic department design and development framework, which is essentially an administrative design and development program to tackle the learning objectives 1, 2, and 3. Okay. So this generic department design will be used to take care of these 3 learning objectives. I have presented this generic department design and development framework last time. I said this framework is generic and is applicable to all kinds of department in the hospital. As such, this is applicable to a department of surgery. It's applicable to a department of obstetrics, gynecology, any department, clinical department, as well as other non-clinical departments in the hospital. The Department of Surgery, let's now focus on the Department of Surgery. The Department of Surgery is one of the various medical specialty departments providing medical surgical services to patient clients of the hospital. The Department of Surgery is one of the subsystems within the hospital, which is the super system, and the other departments like the Department of Otolaryngology, Department of Internal Medicines, and other non-clinical departments are called subsystems. Using the framework, this slide shows the essential and basic components of a department of surgery, which must be present to facilitate accomplishment of the authorized functions and services and achievements of its goals. So see the various boxes in the following with the following labels: leadership, authorized functions, authorized services, goals, architectural design, engineering, construction, fiscal structure, DOH licensing, structural and structural requirements, human resource, equipment, material program, data document records program, business development program, budget program, IT-enabled system, risk management system, policies and procedures, and of course, the regular performance evaluation and continual improvement program. All of these components must be present, aligned, and integrated with each other in order to achieve the performance excellence for the department. On the extreme left of the slide, one sees the need for alignment and integration with the whole hospital, the entire hospital, as well as with other departments in the hospital, the interfacing units. Okay? This slide illustrates also the super system, which is the hospital, and the subsystem, which is a particular department. Here we're talking about the Department of Surgery, and the co-subsystem, which is an interfacing department, other departments, clinical as well as non-clinical departments. Again, all the arrows between and among these boxes indicate the need for alignment and integration of all the parts of the subsystems, which is the department, and with the super system, which is the hospital, and cost systems, which are the interfacing departments. Let me repeat, the administrative design and development program should be aligned and integrated with the whole hospital's concepts and design. Here on the first box, the governance, policies and procedures, operations, policies and procedures, as well as the interfacing units, operations, policies and procedures. In other words, there must be a systems perspective or system thinking. Let's start with the first box here, leadership. There must be a competent head with at least the following competencies: the unit technical requirements and competency on the specialty of the department. So in this case, in this particular lecture, we're talking about the Department of Surgery. So the leader must have competency in surgery. So the head must be a surgeon. Or okay. The leaders must also have a spirit of and competency for teamship or team playership, managerial skill, as well as leadership skills, and with system approach and thinking in managing the entire department. There must be a document that contains the job descriptions, job specifications, and performance evaluation systems of the leaders and managers. As to the functions, there must be a document stating the authorized functions of the department. It must be complete and clear with general and specific functions, and it must be authorized by a higher office. The authorized functions serve as a compass or a guide, describe the roles and responsibilities of the department in the context of the whole hospital, give it authority to do what it should be doing, serve as a guide in determining what are needed in the unit to function properly and adequately, such as in terms of structure, formulating staffing, policies and procedures, programs, and resources. It also serves as a guide in determining what program, projects, tasks, and activities the head and staff can do to accomplish their unit's functions, both on the long-term as well as short-term basis. And it serves as a basis for evaluating the unit's performance, at the very least, whether it is accomplishing its expected function on a daily and basis, as well as on an annual basis. And it should serve as a basis for the name of the unit. So examples of a general function statement of a Department of Surgery is seen here. General function to provide medical services to all patients with surgical conditions and diseases who seek consultation and treatment in the hospital. A very simple statement on the general function. An example of list of specific functions are the following: to examine all patients with the possible surgical conditions and diseases, and afterwards to make a rational and accurate diagnosis. Number 2, to provide treatment to all patients with surgical conditions and diseases. And number 3, to provide training in surgery and to promote research in surgery. Another example of list of specific functions would be the following. Number 1, to provide quality health promotion and disease prevention program in the field of surgery to clients in need of such services, to provide quality and safe diagnostic and therapeutic procedures to all patients with surgical problems, to provide quality and safe preoperative, intraoperative, and postoperative surgical care to all patients in need of such healthcare service, and to provide quality rehabilitative health programs in the field of surgery to all clients in need of such service. So you can see that this set of this example of a list of specific functions is more comprehensive and more holistic compared to the others, to the other one that I just mentioned. So it all depends on the department's leaders formulating the functions of the department. Now, as to the services, there must be a document stating the authorized services of the department. The formulated functions mentioned earlier determine the services to be offered to the clients, which consists of both the physicians as well as the patients. And services offered and functions authorized must be congruent with each other. Examples of list of services based on authorized functions, the ones that I mentioned earlier, will be the diagnostic program, therapeutic program, preoperative, intraoperative, and post-operative surgical care program. So these are the basic services to offer by a department of surgery. Another example, based on the other set of list of functions, okay. Health promotion and disease prevention program, diagnostic program, therapeutic program, preoperative, intraoperative, and postoperative surgical care program, and then rehabilitative health program. As to the goals, there must be a document stating the goals of the department, which are usually the following. This is quite generic for all types of departments. Performance excellence, client engagement, which refers to the number, the frequency of returning loyal patient clients, then quality and safe healthcare services, cost-efficient and value-based services, maximal utilization of services, and which must ultimately result to financial viability and sustainability not only of the department, but also of the entire hospital. Value-based services, just a word on a simple explanation on this term. It means the value created and appreciated by the patient and physician clients likewise for services rendered as a result of good outcomes and results in quality and safe services and associated with reasonable costs and expenses. There must be a document stating the ultimate goals of the department, which must be aligned and integrated with the goals of the hospital. And all the department goals should eventually be contributing to the financial viability and sustainability of the entire hospital. As to the physical structure, so that of the Department of Surgery, this refers to the geographical space or area in the hospital constructed to receive patient and physician clients requesting for services and to house the staff who will perform the functions of the department. The physical structure needs of the surgery department will be dictated by the functions and services, and this include the following. So basically, this include the operating rooms, surgical patient beds and floors, consultation rooms in the outpatient department or clinics, and emergency room, and department administrative offices. The surgeons or department leaders must be involved particularly in the design and development of the operating room, surgical patient beds, consultation rooms in the outpatient department or clinics, and emergency rooms, as they have impact on its authorized functions and services. This department and services are usually managed by the different groups of managers. I'd like to emphasize that the surgery department must be involved and do not just leave it to the architect to do the design of the hospital. The department leaders must take note of this. The service requirement as dictated by the authorized function is the first determinant of the physical structure of the department. The department leaders must also take note of the other departments and determinants of the physical structure, such as statutory regulatory requirements, the Department of Health or Ministry of Health in Malaysia, if you're talking about the Malaysia, okay, licensing requirements. So in the Philippines, there's such thing as DOH guidelines in the planning and design of a hospital and other health facilities and safe hospital initiative, okay, structural, non-structural, and functional indicators. These are seen in the Department of Health. Building code, fire code, local government requirements, specialty requirements, particularly those which have training and research programs, human resource programs, equipment and material programs, data, document, and records program, budget program, risk management program, business development program, quality standards, community expectations, efficiency, caseloads, and of course, what the owners want. This is also very important. The physical structure of the department service areas must be compliant with the Ministry of Health or the Department of Health, licensing and structural requirements, particularly on the location and the size. In particular, specifically, they must comply with the following. Number one, accessibility with clear signage where they are, adequate size. It should not be cramped for staff as well as client movement, adequate lighting, adequate ventilation, aesthetics, attractive enough with a welcoming, friendly, and therapeutic environment, provision of privacy as needed, and comfortable waiting areas. So these are the minimum expectations. As to the architectural design, engineering, constructions, this will be dictated by the DOH licensing structural requirements and the fiscal structure requirements. As I said, do not leave it to the architect. The hospital, the department leaders must have a say, must be advising what are really needed by the department. And of course, the ones prescribed by the Department of Health or the Ministry of Health are just the minimum. You can enhance it, you can add some more as to the architectural design, as long as they conform to the basic requirements. Human resource programs or staff. This consists of doctors or MDs, physicians, okay, specifically surgical consultants, fellows, if there are, and then residents, if there are, interns, if there are, etc. But minimum is surgical consultants, providing medical surgical services on a salaried or non-salaried basis, depending on the situations. The specialists usually consist of consultants in general surgery, pediatric surgery, urology, thoracocardiovascular surgery, plastic and reconstructive surgery, neurosurgery, and other subspecialties. But in some hospitals, especially nowadays, the composition is not the same anymore. This is usually there some subspecialty of the traditional department of surgery have seceded or have become independent. Okay, example, you have the neuroscience. Okay, neurosurgery can be out of the Department of Surgery. It is on its own. Neuroscience, okay, Department of Neuroscience. So in others, you can have the heart department. No, okay, it's not under the Department of Surgery anymore, but independent. So it all depends on the hospital and also on the situations. As to the human resource program, there must be a document showing job description, job specifications, and performance evaluation system of the staff or the human resource in the department. And there must be, what's very important, there must be documentation of the adequacy in terms of number and incompetency. This must be documented. As to the equipment and material program, there must be documents showing the adequacy of equipment and materials. This must be computed. This must be rationalized, needed to facilitate an effective and efficient functioning of the unit in consideration of the key functions and services of the unit. Number 2, statutory regulatory requirements and other objectives like the business development, risk management, and IT-enabled system. As I said, the document must rationalize the requirements of the equipment and material program for a particular department of surgery. There must be a document showing, still part of the equipment and material program. So there must be a document showing adequacy of the equipment materials in terms of in the following service areas. So there are so many areas in the Department of Surgery or related to the Department of Surgery, which are the operating rooms, surgical patient beds and floors, consultation rooms, in the outpatient department, clinics, and emergency rooms, as well as in the department administrative offices. Again, there must be a document showing the presence of a management system of equipment materials, which includes, among other things, which are very important, which are often lacking in most hospitals, the preventive maintenance and calibration, especially of the precision equipment, biomedical equipment. As to the data document record program, there must be a document showing adequacy and accuracy of the data, documents, and records needed to facilitate an effective, efficient functioning of the units in terms of its authorized functions and services, statutory requirements, regulatory requirements, and other objectives like business development, risk management, and IT-enabled system. There must be documents showing adequacy and accuracy of data, documents, and records needed in the following services, okay, operating rooms, surgical patients' beds and floors, consultation rooms, in the outpatient department, clinics, and emergency rooms, department administrative offices. So examples of these records would be the patient's records, governance operations manual, department statistics, and others, etc. As to the business development program, there must be a document showing the presence of a structured and comprehensive program that will develop the business of the unit, which is the Department of Surgery, to make it viable and sustainable. Budget program, document showing a budget that projects the future income and expenses of the unit, and the budget is being used to guide as a guide for day-to-day performance and financial evaluation at planned intervals. Risk management program, document showing a risk management program, which is a planned and systematic process to reduce and or to eliminate the probability of a risk that usually results in injuries, losses, and legal suits. The program may also include risk for potential positive effect, such as improving the business and client engagement. IT-enabled system, the document showing the use of IT, number 1, to promote efficiency in the performance of functions and accomplishment of the services. Number 2, to manage the information of the unit in terms of getting the information, storing, protecting, processing, transmitting, and later retrieving as necessary. To create interconnection with other units in the hospital for timely communication, coordination, and collaboration in the accomplishment of the services of the unit. And to communicate with the patient and physician clients both in and out of the hospital. Policies and procedures, clinical practice guidelines, and clinical pathways. Okay, so this must be all documented. That this will serve to provide order, to promote standardization of the procedures that will be done within the department, and to facilitate communication among the staff, and to promote efficiency and effectiveness, and also to provide as a guide to present and future staff, among other things. This is a record that can be endorsed to the incoming new staff. Now, the policies and procedures must be aligned with the policies and procedures of the hospital. So they must be congruent. And they must be supportive of those of the hospital. And they should be reviewed and revised periodically, which are not frequently done. Clinical practice guidelines, as a definition, is a systematically developed statements which build on synthesis of evidence, which provide formal recommendations, note only recommendations, about appropriate and necessary care intended to assist the practitioners and staff to make decisions about appropriate health care for specific clinical circumstances. So examples of titles of clinical practice guidelines are clinical practice guidelines for acute appendicitis, breast cancer management, gallbladder stone management, etc. So these guidelines must be formulated, be present in the department, and then approved and concurred by all the department staff. Pathways, the difference between pathways and the clinical practice guidelines is that pathways are interdisciplinary, okay, different discipline coming in, and not only the surgeon, but the nurses and other non-medical staff, okay, on the plans of care that outlines the optimal sequencing and timing of intervention and expected outcomes for patients with a particular diagnosis, procedures, or symptoms. So examples of clinical pathways are pathways of acute appendicitis, from diagnosis to operations to finance settlement, etc. Okay. Then elective cholecystectomy and others. Regular performance evaluation and continual improvement program. This must always be present, but which is not regularly done. There must be a document that shows the program to appraise the extent of accomplishment of the unit in its authorized functions and business plans at the very least. Okay. At plan intervals, example, quarterly, biannually, or annually, and then also to determine the areas of improvement and to act on them. At this point, I'd like to say that I have covered learning objectives 1 to 3 using the department design and development framework, and I have tackled the philosophy, objectives, structure, staffing, policies, systems, and methods in running a department of surgery, the roles and relationship of the department, different components of a department of surgery, and lastly, the responsibilities of hospital managers in directing and coordinating the department of surgery. Let's now go to the last learning objective, which is common challenges encountered in the governance of the Department of Surgery together with their suggested strategic solutions. The challenges can be at least in 5 categories: man, systems and methods, machine and equipment, money and other resources, trends in surgery. Under man categories are the consultants. The players here are the consultants, fellows, the residents, if there are people like this present in the department, colleagues in other units, in other departments, the bosses, the chief of hospital and other bosses, and of course, the subordinates like the non-medical staff. Okay. The common problems encountered here under man categories are the competencies. Number 2, quantity, enough or not. Alignment and coordination, collaboration, and integration of all the things that they are doing. And of course, personality, which is the most difficult thing to handle. Okay. Suggested strategies consist of leadership and managership skills of the leaders, of the department head. Then managing your boss, especially managing your chief of hospitals or other bosses. Okay. And then use of multi-sectoral and multi-professional committee membership to have a participatory management approach in the running the hospital in the department. Under the system and method categories, the common problems are lack of systematization in doing things, lack of standardized procedures. So there must be a manual that will spell out the that will standardize things. Okay, example will be use of DOH licensing requirements as a guide. That's the minimum. And then use of the quality standards as guides, such as the PhilHealth Bench Book, if it's still existing in the Philippines. I have no idea now where it is. Okay. Joint Commission International, this is an international quality standards. Accreditation Canada, which is present in the Philippines. And then also to establish policies and procedures that will standardize things like the clinical practice guidelines and clinical pathways. Under machine and equipment categories, the common problems are the lack of management system, lack of calibration, and preventive maintenance of the machines and equipment. Suggested strategies will be policies and procedures on use of the equipment and machines. And then under the money and other resource category, okay, so we always remember that this is a perennial problem. Okay? It's always a problem, the limited resources. And that it all depends on the leadership and innovativeness of the leader on how to get the needed resources. Then the trends in surgery category, the most common problem is the rapid changes in trends, which often are difficult to cope, especially nowadays for the past 10 years. Okay? Suggested strategies are putting up a knowledge management system for the entire department. Okay? So here we try to track what are the improvement going on within the in the field of the Department of Surgery, and then continual education. Then we can also do benchmarking with other hospitals. And then, of course, there's a need to be innovative in all the new things that will be coming out, because we cannot just follow whatever are new in the world, in the community. So we have to be innovative to make it more efficient. I like to end my lecture by flashing again the topics that I have covered. Number one, understand the philosophy, objectives, structure, staffing, policies, systems, and methods in running the Department of Surgery of a hospital. Understand the roles and relationship of the different components of the Department of Surgery. Describe the responsibilities of hospital managers in directing and coordinating the Department of Surgery. And lastly, understand the challenges that might be encountered in the Department of Surgery and recommend solutions thereto. My parting advices, remember and use this framework. As I said, it is generic. It is applicable to all departments, clinical, non-clinical, in the entire hospital. It is comprehensive. It facilitates learning, planning, and governance of a department. The thing to do now is just put in the details, the contents in each box, and compile them into an operations manual and just keep on revising it as needed. And also remember the starting table with the 5 categories of man, system, methods, machine and equipment, money and trends, and recall the common problems under each category and my suggested strategies. You can add more as needed based on your situations in your setting and your circumstances, particularly on the strategies. With this, I conclude my lecture. Thank you.
Thank you, sir. Thank you, Dr. Joseph, for that very, very informative lecture. No? So I think we now open the class for any questions that you have to our speaker. Anybody wants to ask questions to Dr. Hosan?
I will try
Kindly
my
use
best because I know some of you might have
But it's
questions
in the questions,
based
sir.
on your circumstances in your hospital. Any questions?
There, Dr. Maria Mesran is raising her hand, sir. Go ahead, Maria.
Maria.
Yes,
Hi.
hi, Prof. I just would like to share our experience in Malaysia as well as in Sarawak, especially in district hospital without specialists. In the all times actually have operation rooms, but the OT was actually the cases was actually managed by assistant medical officer specialized in anesthesia instead of medical officer. So usually in the old days, the department is actually led by the assistant medical officer in the anesthesiology instead of medical officer, because in the old days we don't have enough medical officer and they are not usually trained in surgical department. So until recently that when we have more doctors, then the doctors will let the team in surgery. Just would like to share the experience previously.
Okay. Thank you for sharing. I think that's true also in some parts of the Philippines, okay, in the remote areas, no? So as the hospital director, as the head of the hospital, you just try your best, no, to do whatever you can do in that circumstances, no? So as I said, the best scenario will be a surgeon heading the Department of Surgery. But if you don't have a surgeon and who is not qualified, then you can get another one who might be qualified in terms at least of leadership and managership. And then for the specialty, probably it's either he tries to learn to be a surgeon, or you can wait for a surgeon to come in the future. No? Okay. Thank you for your sharing, Maria. It's nice to have to hear some sharing because I think, as I said, we have different situations, not only in the Philippines but also in other countries in terms of the operations of the Department of Surgery. No? And I like to learn from you also from your sharing. Any other sharing or questions?
we do have a
There is a
question
chat in
from the
questions,
chat.
sir.
Yes. Sige, Doc Charlie, sorry.
Hindi, okay lang. Please go ahead.
Okay, so there is a question in the chat. How do you, from Hermes Palad, how do you resolve the problem with overlapping of specialties within the
Oh,
department?
okay. Is this coming from the Philippine setting, or is it also true in Malaysia?
From the
Malaysia.
Philippines, sir.
Yeah, or the Philippines, but is it also true in Malaysia? It's a common problem.
Yes, Prof. Yes,
Right.
we do have the same issue in Malaysia.
Yeah. Okay. So that's why it's very important, as I said, once you in the department design, administrative design, in the authorized functions, now you spell out what you are supposed to do, and then you let you discuss it with the other departments, the other departments that might have an overlap in your functions, and then come out with a consensus on agreement. No, it's either sharing or probably giving in, okay, to one department doing the work, these specialties, okay, and then just work in harmony with each other. But the bottom line is just think of the patients that you're going to serve. No? Okay. So it's true that there are a lot of overlaps. Okay. So would you like to mention some overlaps, Hermes?
Personally, working in a government hospital, I was just around 4 or 5 years from this government hospital. When I started in this institution, um, the general surgeon was the one who was doing orthopedic surgeries.
Okay.
He was working in a very far-flung area from the general surgeon was able to do external fixation and or if for our patients. However, when I came in, there was a problem because the patients were confused whether going to my clinic or to his clinic. So until now, some although we are trying to have division of the patients or telling them that to go to proper doctors, still the problem still continues.
Okay. Can I assume that
So
you are the orthopedic surgeon?
yes, yes, yes,
Okay.
yes.
Okay. So let me okay. I think you have to consider the history also of the specialization, the medical specialization. No, it all started with a very generalized, specialty that covers a lot of things. As I said earlier in my lecture, when we talk about the traditional general surgery, it includes all the various departments that are on the cutting edge. No, even obstetric gynecologist was before under the Department of Surgery. If you talk about the history, no, and then eventually it seceded. I said seceded, it became independent. No, okay, it's now on its own. No, the ophthalmologist before was also under the Department of Surgery and ENT. Anesthesia was also part of the Department of Surgery. During my training, the Department of Anesthesia was under the Department of Surgery, but eventually, 1 year after my training, it became independent. No, okay. So we just have to consider the history and then just have a communication, the friendly persuasion that which scheme, which approach would be the best for the patients. No, okay. So example will be probably overlaps here will be Department of Surgery and also Department of Otorhinolaryngology, okay, which also do head and neck surgery. General surgeons are also doing head and neck surgery. Okay. So there might be some quarreling, some turfing of the cases, but the chief of the hospital would just have to gather the two heads, the two specialists, different kinds of specialists, general surgeons, and the otorhinolaryngology, and come out with a win-win situation, all for the sake of the quality services for the patient. No? So that's an example of the ENT versus general surgery. Probably nowadays you also have overlaps between orthopedics and neurosurgeons, okay, with regards to spine surgery. Again, the same approach. No? The chief of hospital will have to talk to the various specialists and then try to come out with a solution that will be useful, not primarily for the patient, but also for the specialist. Okay. Did
Okay,
I
so we
answer your
have
question, Hermes?
Thank you, sir. Thank you, sir.
Okay.
so
Okay.
we do have a couple of comments from the chat.
Okay.
From Dr. Hazwani. In Malaysia, also, we have the same issue, especially in big hospitals. There are always not enough. I assume this is operating theater time for all specialties.
Yes, yes.
In the end, the surgical committee of the hospital will have discussed and fairly decide according to the demand of the services. If it still can't resolve, uh, the final say will be from the hospital director.
Okay.
Okay.
Correct.
And then
Okay.
from Dr. Michael Te. Okay, the problem in our facility is that no surgeon wants to become the head of the department as it will detrimentally affect their earning capacity.
Okay. But there are some situations, some hospitals in which the surgeons really want to become the head. So it all depends on, as I said, one of the common challenges is the personality. Every person will have its own personality. Okay? So if you cannot find a surgeon who wants to become a head, try convincing one if you are the chief of the hospital, or look for another one. Okay. So nowadays, if you are in the city, it's relatively easy to find a head for the Department of Surgery. Okay. So related to that question, Michael Te, no, there are some surgeons who don't like to become head of the Department of Surgery in a government hospital because the earnings not that much. They prefer to be head of a Department of Surgery in a private hospital. Okay. So it really depends on the chief of hospital now, the hospital director, on how he will solve the problem. Okay. Any more?
Any more questions from the class? Going once, going twice. Okay, so if there are no more questions, I would like to thank everyone for coming. Thank you very much, Dr. Hosan, again, for gracing us with your presence and with your knowledge and expertise. Let's all give a virtual clap to Dr. Hosan and to everyone. Okay, and before I close the class, do we have any other announcements, Dr. Gundran?
Let's have a picture taking.
Ah, yes, of course.
Picture taking for Dr. Roson. And I have reposted the link to the OLET. Please consider this as your quiz. No, so if you don't answer it, you are answer and the answer until you get a perfect score. So the link to the OLET is in the chat box.
I'd like to thank those who make repeated attempts to get a perfect score for the OLETE. I like to thank them. No? Okay. We'll have another OLETE. No? Okay. So let's
Please
have a
open your
group-
cameras for another picture.
2 pages, Beto, 2 pages. One,
Yes, sir. We have 2 pages.
one. I'll also take pictures from my side. 1, 2, 3. Wait, I will have to. Page 2. Page 2. 1, 2. Okay. No more questions? It's still early. Okay.
If there are no more questions, then I guess let's call it a day, sir.
Yeah. Okay.
Okay,
Sige.
We'll have
so thank
we'll have
you,
the other one
everyone.
the next week. We'll have my last lecture will be next week.
Yes, sir.
Yes, sir.
Okay. Quality, no?
Yes, sir.
Okay. Thank you.
Hospital quality accreditations. Thank you very much, Dr. Hoson, and thank you very much, Patrick and class. No? So that's it. No? Have a nice day. Class dismissed. Bye, everyone.
Thank you, Prof.
Thank you, Prof.
Bye.
Link.
Thank you, Prof.
Bye.
Bye.
So Hermes should stay behind because we have to discuss something. No, Hermes.